Yvette. I'm one of the co-directors at the Molly Wardaguga Research Centre. And I want to acknowledge that I'm on the sovereign lands of the Larrakia people up here at Gurumilla in Darwin, and acknowledge our elders past, present, and young people who are emerging, and acknowledge that the sacrifices that our elders and ancestors have made for us to be in this forum today. I want to acknowledge the other Aboriginal and Torres Strait Islander people in the forum, but also our non-Indigenous allies who we need to work together to do some really important work to improve the outcomes for our mothers and babies. We're really excited this afternoon to have Suzanne and Vanessa to present on a really important topic about how do we get better outcomes for mums and bubs by redesigning, having a workforce that's prepared and can work in various conditions. And Suzanne and Vanessa is going to talk about working in remote conditions. So I'm going to hand it over to them to do their introductions and share their wisdom with us this afternoon. For those who have questions, please put them in the chat box and we'll come to those at the end of the presentation. Remember, there's never a silly question. And if you're thinking about that question and you feel too shy, remember someone else might be thinking about that question as well. So again, thank you, Vanessa and Suzanne, for your presentation this afternoon, and over to you.
You want to start?
Please
introduce yourself.
Hi, my name's Vanessa Radcliffe. I'm the outreach health worker. I travel to 2 communities, Doomadgee and Mornington Island, and I also help in town with MGP.
My name's Suzanne Weir. I'm the manager of the Midwifery Group Practice for Northwest Hospital and Health Service. I also manage the outreach midwifery programs, and I never do anything without Vanessa. So we're going to present a very simple presentation today, and please ask any questions if you know, we haven't presented something that you'd like to ask about.
Suzanne, just before you continue, Vanessa, you're a little bit away from the microphone, so can you just talk up nice and loud? Because I know that I'm half deaf in one ear, so if you could talk up a little bit louder, that'd be super duper. Thank you.
So we also are in the middle of the desert, and we do drop out of Zoom a bit, so hopefully today will be okay. Vanessa's going to start with an acknowledgement.
Okay. We would acknowledge the First Nation traditional owners, the cultivating people of this land, on which we meet and celebrate the enduring connections to country, knowledge, stories. We pay respect to the elders, past, present, and emerging. We also extend that respect to all First Nation peoples. We acknowledge our gratitude that we share their land, waters, and skies today on sorrow for the cost of that sharing, or our hope and belief. We can move to a place of equity, justice, partnership together.
Thank you. Okay, so today we're presenting on midwifery continuity of care and carer models in Northwest Queensland. We would like to acknowledge all the work that has gone before we came here, and we also want to praise our executive who had the foresight quite a few years ago to know that continuity makes a difference. Oops. So we do live in the desert, but we live in a spectacular part of the country. We are very isolated, but that just makes us a family. We work and play and spend a lot of time together. So really simply, the aim of our midwifery programs are to provide an evidence-based, culturally safe maternity service that really meets all the needs of our mothers and our families living in northwestern Queensland that come in, join us with and when they come into to our services. A little bit about where we are. So you can see that where the tick is, we're in the northwest of Queensland, and then a little bit, if we elaborate a little bit more, you can see it's a huge area. It's 300,000 square kilometres that we run midwifery programs to and from. We have various programs, and we'll talk about them a little bit more, but we have outreach programs where we fly to community and the women come and relocate when they want to have their babies around 36, 37, 38 weeks. And that's Doomadgee, and way up the top in the Gulf, you can see Mornington Island. And this is myself. I don't think you came that day, Vanessa.
No.
This is on our tiny little plane where we bless ourselves every time we arrive, especially in the summer and the wet season. Then we have Cloncurry, and most recently Normanton, and we have midwives that are based in those communities, and they provide antenatal and postnatal, and they may or may not birth with MGP midwifery group practice when they relocate to ISA. These families, they often choose to maybe have their babies with family, so they'll go to all over the place, from Tweed Heads to Cairns to wherever, and then they'll come back, and then we'll pick them up postnatally. And then you can see in the centre, it's Mount Isa. That's where we're based. And just wanted to mention the high Indigenous rates that we do service. You can see here, Mornington Islands, 87% Indigenous, 94% in Doomadgee, Normanton's about 50%. A little bit about the service, and there's our gorgeous Doomadgee midwife with one of our bubs. We've got consent for all the photos that we're using today. So it's about 55%, isn't it,
Yeah.
of all our families are Aboriginal Torres Strait Islander, or the babies identify. We have between 450 to 500 births per year. We're very lucky that we have 2 permanent obstetricians that are based in Mount Isa, and we have a PHO, a registrar that trains every 12 months. The hospital itself, it's got 12 beds and it's got 3 birth suites. We're a level 4 hospital, but we often flex up. So we've got a special care nursery, and we keep babies as 32 weeks and up. We've got an on-site theatre and on-call theatre team. So we do all our caesareans, twins, complex diabetics, BMIs over 50, and lots of other high-risk stuff. Our referral hospital is a long way away. It's 12 hours by road and 2.5 hours by retrieval services. And our referral hospital and our FMN is Townsville University Hospital. This is just a bit about our population. I'm sorry it's such a busy screen, but I just wanted to give you some context about, I guess, how complex the women are that we care for. So the Aboriginal and Torres Strait Islander women and families that are living in the lower Gulf, they experience a very high disproportionate burden of disease compared to the rest of communities in Australia. the significance of this disparities were reinforced when we completed our health equity strategy recently. And some of the data that indicates this is that we've got the highest mortality rates in Queensland. We've got the second highest morbidity burdens in Queensland, particularly in relation to preventable chronic diseases. And so what that looks like is we are often caring for women that are obese, diabetic, RHD, psychosocial, very complex. And their fertility rate is over 2.5 times that of the rest of the women in Queensland. 71% of our Indigenous pregnant women in Mornington and 64% in Doomadgee smoke, compared to 52% of women across Queensland and only 21% across Queensland. It's not uncommon for our mums to be smoking half a pack a day. So smoking cessation is a big priority and health target for us. Indigenous infant mortality rates are 3 times higher than all of Queensland, and up to 75% of Queensland and Doomadgee and Mornington Island are classed as developmentally vulnerable. So a bit about where we came from and where we are now with our midwifery models. So we started off probably around 2010 with a complete obstetric model of care. And then these dates may or may not be completely accurate. They might be a few years out, but we moved to we started with a midwives clinic, and that was really the beginning. And then in 2012, we got some Making Tracks funding for an outreach midwife, and that midwife went and serviced Doomadgee and Mornington Island every fortnight and ran clinics, antenatal and postnatal clinics, and it was a huge success. We saw our engagement increase, our do not attend rates increase when they were co-relocating for birth, and that funding continues to today. In 2015, we were lucky enough to have an awesome midwife move to Cloncurry, and the community based a maternity MAPS, if you like, service around her. So she does antenatal and postnatal for all the women in this huge area. Cloncurry, McKinley, she travels around a 4-hour trip every week to Julia Creek to see the mums there. Then we were lucky enough in 2020 to secure to introduce a second midwife. So we now have a midwife that is dedicated to Doomadgee and then Mornington Island, and they cover the roster so that when the women come down to birth, there's always a known midwife for them, and we see great outcomes because of that as well. Do you want to talk about because you're attached to that?
Yeah. Then in 2020, I secured the job as the outreach health worker, and I travel to both communities, so I'm gone every week.
Pardon me.
So I'm gone, like, we fly up Mondays, we stay overnight, we come back Tuesday. So yeah, majority of my time is up on the island or in Doomadgee, and then from Wednesday onwards, I just in the ISA when the girls come across.
And you often attend their birth.
And I attend their birth. So I support them if they don't have anybody in labour. I attend their Caesars with them. I also help get them to their appointments and birth registrations, and yeah, I'm like a mum.
Everything else. In 2019, we got some Queensland Health funding for 4 midwives to commence a continuity program, and we also moved some positions across from the core model. So we started with 6 midwives. That was including a graduate midwife, 1 or 2 graduate midwives, and a manager. And we also have just introduced an Aboriginal assistant in midwifery who's studying her BMid. In 2023, which was this year, we also introduced another community-based outreach midwife in Normanton, and she does that whole top of the Gulf as well, Karumba and Burketown. And we realised that even though there's only a small number of pregnant and postnatal women up there, they didn't have any antenatal or postnatal care at all. So they were extremely vulnerable. We had some clinical incidences, and in response, we've put this midwife in the community, and it's just gone incredibly well. Everyone's engaging with her, high uptake, more women are coming down to birth in Isa. In 2022, we, after lots of battles, we've introduced water birth. And in 2022, the most exciting thing, 2023, sorry, that's an error. We've just secured some funding for a sonographer to go to outreach communities on country. So, and this is huge for the women, because when we're doing the health equity, and recently when we were doing consultation, their biggest issue was having to come down to Isa and leave their families and go off country for the scans. And some women, because they are complex, they're having up to 5 scans sometimes before they come and co-relocate for birthing. So that's really exciting. So we're going to see, I think, more uptake with our scans and less do not attends. We partner with the local Aboriginal health organisation, which is Gidgee Healing. The midwives sit in the Gidgee Healing premises when they do their outreach clinics. We also work with lots of ARCHOs, non-government organisations in town. Our main ones are Nukathati and 54 Reasons, and they help us with the really vulnerable women to do wraparound support for them. So it's ongoing, our co-design with Gidgee, and we're getting closer and closer towards that model that we want. But there's many issues, isn't there, to that co-design process. So some lessons that we learned when we started our MGP was we realised we started with a low-risk model, but we quickly realised that probably about 70% of all our mums, according to the ACMI National Guidelines for Consultation and Referral, are Bs and Cs. So we've transitioned to an all risk no exit model. So anybody that wants MGP, a First Nation mum can access it. Our model is from as soon as they know they're pregnant, it's self-referral, they don't need a doctor's referral, and it's for up to 6 weeks postnatally. We've reduced, we started, each midwife had 40 women and families per year. We realised that due to the acuity of the women, we needed to reduce that because the midwives were burning out. So we're sitting at a caseload of 34. Our grad takes 27, and the CM who's precepting the grad takes a reduced caseload as well. All the outreach caseload numbers are uncapped. We take whoever in the outreach communities who wants our care. Will go above numbers. We work to our full scope. I don't know whether you want us to go through some outcomes. So I've just got a few. So we're now in our 3rd year of operation, MGP. A lot of our mums, we have a very high that belongs here. We have a very high induction rate. As you can see, the Queensland rate's 33.5%, and we sit around 43%. And it's many reasons, and we have brought that induction rate right down, but for an MGP model, we'd like to see that lower. But because we are so far away from our referral hospitals, sometimes we have to err on the side of caution and intervene sooner than later. You can see also, interestingly, but our primips are sitting around 36, which is probably looking pretty good for the state average. And Vanessa probably knows this more. I think also why our induction rate is higher is because our mums that come off community, if you come at 36 weeks and you're away from your family for a very long time, if they go over 40 weeks, they'll start asking us for an induction, don't they? Because they need to get back home and be with their families. So it's something that we're really aware of, and we'd like to fix. Our caesarean rate's fantastic, even though we've got a higher induction rate. If you look at the perinatal data percentage for caesareans, it's 37%, and we sit around 21%. So I think that's not only the whole service that works to support the women, but it is that continuity of care that makes a difference. Also, our instrumental vaginal birth rates are on par with the state. They're sitting smack on. So that's, we can always do better, but I think for a very high risk population, that's reflective. Our epidural rates are low compared to the rest of the state. So I think that's that continuity and having a known midwife makes the women feel safer, and they will try more things before they go through the epidural with us. You can see our neonatal outcomes are twice, our transfers are twice the state average, and that's because of our mums and their complexity. We have huge rates of insulin-dependent diabetes. We have a lot of babies admitted to the nursery with hypos. We have so that's mainly often the reasons. We also have a lot of transfers because we need higher care. So say if we have, we've kept a baby, for an example, because it's got a cleft palate, but the baby's not, we've tried our management plan here, but the baby's not feeding, then we'll transfer to where there's more resources for that baby and that family. Our breastfeeding rates is good. It's above the state average of 72. We're sitting at 76, but also a lot of the mums do a lot of mixed feeding here. It's very entrenched out here, so it's something that we're trying to work on, especially that initial breastfeeding to just exclusively breastfeed. And these are our continuity of carer rates. These are all benchmarking. We just were benchmarked with Women's Health Australasia. So they're the stats from WHA. So you can see that we are doing really well. The primary carer, 62% of the time, sorry if that, oops, I can't. I'll try and make that a bit bigger for you. I don't know if you can see that now. So, current slide. So you can see that 62% of the time the midwife is present at the birth, but for about 77% of the time they're getting their primary midwife or their backup midwife, and that might just be because the primary midwife's fatigued and she needs to swap out, and then the backup midwife comes in, or she's at another birth, or she's up in the communities and can't provide care. But that's that's something we're really proud of. So our future, look, we're always looking at expanding. We're always looking at being more culturally safe, more culturally inclusive. But what we ideally are moving to next is an actually designated First Nations MGP team that's based in Mount Isa. And that's a whole team with a health worker and hopefully a identified student midwife, and they're Aboriginal midwives and they're caring for Aboriginal women and families. That's our ultimate goal. We'd love to have more scope for our health worker as well. We are very under-resourced. We don't have a dedicated social worker. We don't have any maternity designated, diabetes team, social work. There's high vacancies in our service. So our health worker tends to act as admin a lot of the time, and she needs to do more clinical because the women really love being with her. And our executive and a few of us are putting up our hand to be the pilot site for home birth when Queensland finally gets endorsed for home birth. So that's the end of our presentation. Thank you so much for listening.
Thank you so much, Suzanne and Vanessa, providing such a inspirational and comprehensive overview about the developments in the region. I'll go through the questions that have been posted and let you get your breath. It is quite nerve-wracking when you're presenting, and especially being so far away. There was a comment from Marilyn Kelly. Fantastic work, Vanessa and Sue. Thanks so much for sharing. Loved all the data. Unfortunately, I have to leave, but thank you again for sharing. Then there was another question. So that was a congratulations from Michelle Koziak, who's an educator at ACU and has been doing that for a long time. Can you tell me about the dates of IOL? 36 to 37 weeks. Over to you, Suzanne. Or
mute.
So induction of labour?
Yes, induction of labour, sorry. I've just got some guests in the room with me. Kate Ragg, who's Morichi, and Helen Blackman, who are from the Wimala unit. They were very interested because a lot of our students are coming rural and remote, so that's why I asked them to come and listen.
So over to you, Vanessa.
Can you just repeat the question again?
Sorry, the question was, when are you taking women off country? Like, I know.
Okay, so we get the ladies off country about 36 weeks.
36, okay.
But then most of the time they refuse and won't get on the plane.
Yeah, good on them.
Yeah.
Um,
Sometimes they come at 40.
yes,
Yeah.
or sometimes they'll birth.
Mm-hmm.
And I know it's really hard because they've got to leave behind their families. They come over here. Sometimes like they'll bring an escort, which could be like their partner, maybe not their partner, but their mum.
Mm-hmm.
And like you feel for them because they've come here to birth and then they're here for quite some time. Like, yeah, it's a long time.
Okay, thank you.
Just going on to that question, Vanessa, one of the questions is when they do come in from community, where do they stay? And what kind of sort of experience do they generally have when they do come into birth? Okay,
when they come, there's a few places that they get booked into. One is Pamela Hostel, which is it's like mainly for Indigenous, but there's not just pregnant women there. There's renal, they stay there. Then there's also Townview Motel, which a lot of them like because a lot of the like Mornington Island, a lot of the families stay there, so they feel more safe. Then we've got Central Point, which some of the girls are not happy, and then we've got another place called the Backpackers. So we ask them where they want to stay. And then if they decide they want to stay somewhere else, they've just got to pay the first night and then they get covered for the rest.
And a lot stay with family too.
Yeah, if we've got family here, we try and get them with family.
Mm-hmm. Well, we know generally accommodation, especially when you're moving off out of home, is always quite a contentious issue. One, about safety and access to services, and also people having money when they do come to town. There are always issues. And I assume that, like in the Northern Territory, you guys have the same frustration regarding patient-assisted travel and how that can be a big headache. So I'm sure that's something that we share across the North. One of the questions online, the comment is, great outcomes. What time period is the data showing the perinatal outcomes for?
21, 22.
Yep. And so we've got 2 years. And do you have a research framework around those numbers to see where they're going?
We very much would like to, but as I said, we're so under-resourced. I just made, when I set the program up, I made it a priority that we were going to take every stat. Yep. And make every stat. So nobody likes doing it. We take it in turns. But I hope to one day to be able to at least trend that data from when we started to where we end up, because when we were starting with like 57% of inductions.
Mm-hmm.
So it would be really great to be able to show the work that we're doing, and also see the gaps where we really need to improve on.
And numbers are a very powerful advocacy tool as well, I guess. Last week in Brisbane, the Growing Deadly Families had a conference in Brisbane. Do they come out and visit your site as well?
We went to the Growing Deadly Families. Do you want to comment?
We went to the conference. It was interesting. And yeah, the girls did come. We saw Melita, and
they did come. We
took them up to Mornington Island.
Yeah, unfortunately, we've missed out on some funding, some very necessary funding. So, but it was really inspiring to see the showcase and to see, but it was also really disheartening to see that we have got such high numbers of First Nation families and what little we have as well. But as I said, you know, when your executive are behind you to really improve, you know, to introduce and grow continuity, you'll get there in the end, you know.
You mentioned in your presentation, again, one of the questions that you did say in your presentation was the importance of co-design with Gidgee and other community organisations, and that's really important. Fiona is asking the question, what type of governance structures do you have with the Aboriginal Community Controlled Health Services? And, you know, is that sort of outlined in a MOU?
Me to talk to that one? Yeah. Well, it's a fantastic question. A lot of our co-design is based on handshakes. And I think that it can be a barrier. We had, for the first time, an MAU with Gidgee to introduce the Normanton community midwife. And that was fantastic in that we actually sat with Gidgee in the room, well, via Teams, and we designed what that position was going to look like. But we're really relying on our health equity because so much consultation was done with our with Gidgee and our other ARCHOs that it's kind of all in there. But we also have an MAU with Nukathati, and they're an NGO, but they provide a lot of programs for the women in town. And so that's about trying to work with them to provide the services in the community more, rather, because the women are not, you know, they don't want to go to the hospital for their care. So, and that's quite a nice place, isn't it?
Yeah.
So, but more needs to be done in that space. And I think it is definitely the way to go, because then you can always refer to the agreement.
One of the things you mentioned also was the complexity of the women. They you know, you talked about comorbidities, access to timely, comprehensive healthcare, things like that. Can you sort of talk about that integration between maternity and primary healthcare services, so the woman can get integrated, comprehensive care? How does that work, or what are the lessons that you're learning when you're trying to make it work?
That space needs a huge improvement. Unfortunately, at our Gidgee, there's a huge turnover in what happens is, because we're so remote, particularly, you know, say somewhere like Mornington Island, and, you know, like Vanessa's the glue for our program there, because she's been going for 3 years. Everybody knows her. But what happens is we'll develop a relationship, and it is always about relationships, as you know. We'll invest and we'll develop a relationship with the Gidgee manager.
And then they get up and go.
And then they turn over really fast.
Yeah.
So it's really hard to introduce new things, because there's no one to, I suppose, champion that. That's our biggest problem, really, with our co-design here. I don't know if it's like that in the NT, but there's, you know, nobody seems to stay for a long time. So, and it's very loose, the handovers. So that's our real struggle with trying to get primary healthcare. Like, even when we're not on country or we're not in community, say a woman needs an urgent GTT, we rely on Gidgee, but they may or may not have a practitioner to be able to offer that. So then the woman might miss out on a couple of weeks of, you know, getting a delayed test, and then she comes back and she's positive, and it's 2 weeks that you've missed for that baby to intervene and provide, you know, appropriate care. And it's like that for
Somebody as well.
Yeah, it's really hard.
And then the other thing is, you find a lot of both communities don't want to access Gidgee healing, so then you're kind of stuck. Like it's if you ask them to go and say no, there's no confidentiality,
or we don't have relationships. So it's just, it's trying to, and this is part of the health equity plan. We're trying to resolve this, you know, to build that bridge, I suppose.
Yeah, it's an interesting observation. Recruitment in remote and very remote areas, whether you're working for the state or territory health services or community controlled, is really at a stretch right now. And, I've spoken to people in Tennant Creek, Alice Springs, in working in East Arnhem, that, recruitment is costing a lot of money, but also people aren't staying for a long time as well. So I think, and that's regardless of whether you work for the NT Health or community control. So those pressures are in the system about our workforce. I guess it's the other stuff is that community control is one provider. We also have mainstream providers, and they need to step up in that space as well. I'm just going to open up to also give you guys a bit of a breathing space. I've just got a request again from South Australia. Is it okay if we share, if they get a copy of your presentation, she can share it with her team in South Australia at Women's and Children's Hospital in Adelaide, if that's okay? Sure,
just the dates, the timeline might be a few years out, but absolutely, yeah.
No worries. I'm just going to open up to the whole. Suzanne, do you mind just stop sharing your screen, and I will just allow me to look at everybody all at once? Thank you. Are there any other questions from the audience for Suzanne or Vanessa?
Yes, it's Desley here. Can you hear me?
Yep.
Oh, good. So I'm a midwife and nurse from the Northern Territory, from Darwin, and I'm working in the rheumatic heart control program. So I have a particular interest in what you were saying about having women birth who have rheumatic heart disease, and I'm wondering what opportunities there are for women to actually be screened for rheumatic heart disease before, when they're pregnant, if they've never had an echo before, because we find probably 3% or sometimes more of women have no opportunity to have known that they had rheumatic fever, and then they've been discovered to have rheumatic heart disease, probably about 3% of women who birth. So I'm interested in your experience, because I know in Dormitory there's a high number of women.
Most of the women, like, when they come, some of them are like nearly 25 to 26 weeks. So then we just get, because they have an RHD that goes out there, a nurse. So
right.
A lot of the follow-ups we get told from them, and then or the girls will even tell us, like they're due for their bicillin.
But I think they're known RHD. It's a really interesting question that you're asking. How do they know, especially in that early stage, whether they are RHD positive? So, I mean, we have high rates here, and we have an RHD team. So I'm going to ask them that question.
Yeah, because there's quite a lot of discussion about screening for pregnant women. And I was wondering whether the sonographer was also trained in echo technology, because if so, that you can use them for both things.
Oh gosh.
No, you don't need to answer me. I was just
I mean, I don't. We've just had such limited ultrasound capacity in the outreach. I wouldn't think so, but yeah. But yeah, it's a great opportunity when they're pregnant, maybe to have that screening. So I'll take that back to the team.
Thanks for that, Suzanne. Michelle also has just whilst we're talking about sonographers, is it extra that the sonographers can partner with the model of care?
Yeah. So I was trying to say, well, if you're going to get stenographers to go out there to do obstetric ultrasound, couldn't they partner once a month with someone that does echoes to come out and do it? Like, I mean, isn't that the high risk time when women are pregnant that it will show up? Like, I think it's about changing your thinking and trying to get people to change their thinking. Yeah, there you go.
I mean, our new service hasn't started, but perhaps they have that capacity because
sometimes you just have to suggest something and they go, oh, we could do that. Oh, wow. So
we've suggested it many times.
I bet you have, yeah.
So I can't see any more hands up and questions, and there's a flooding of thank you and for your time and sharing your wisdom, Vanessa and Suzanne. I'm going to give you the last sort of call on this one. Your 3 take-home messages that you want people to really, what's the key learning that you'd like to share? The 3 things that they have to remember from your presentation.
I think mine is don't give up. Yeah. Engage everyone, particularly your consumers, to fight for continuity. And it can take, it might take years, but if you continue it, that's what women want. We know that that's what women want. We know that that's what the evidence shows. And I mean, who doesn't, especially when you are coming off country, who doesn't want to know who's going to be birthing your baby? I think that's really important. And I just wanted to say that it's a fantastic place to work. I've been lucky in my program that I've had really high recruitment rates, but if anybody wants to experience an amazing opportunity to work with First Nations women and an incredibly hardworking, dedicated team, then yeah, come to the Northwest. I'm going to give you the last 2.
Mine would be, I would love to see, which I don't know if it'll ever happen, birthing on country. Yeah.
I'm going to leave you with that.
Yeah.
Thank you so much, Suzanne and Vanessa. Can everybody just put their camera on, and can we give a really big thank you, acknowledgement to Vanessa and Suzanne for their terrific presentation today. Thank you so much for your time, sharing your wisdom. And like I said, there's a number of people that are going to access your presentation because that really relates to where they are, both out bush and also in the urban setting. So again, from the team from the Molly Centre, thank you so much. We wish you well. We might have to have a yarn to you regarding that number story and see how we can help out there. So thank you very much. And for those who want to access it, I think Kayla's posted something in the message about how to subscribe and how you can access this presentation and previous presenters. All right. So again, everybody, thank you for your time this afternoon, and a special shout out to Vanessa and Suzanne out there in Mount Isa. All right. Cheers.